What are the advantages of episiotomy? Maternal advantages include it's a clear and controlled incision which is easy to repair and heals better than a lacerated wound. Because in the lacerated wound it will be very irregular. So then the suturing will be difficult and the anatomy cannot be reconstructed. Then there is a reduction in the duration of the second stage of labor. And then there is a reduction of trauma to the pelvic floor muscles. So what are the fetal advantages? It minimizes intracranial injury, especially in premature babies, so that they are not there on the perineum for a long time, and also the aftercoming head of the breech, when that can get stuck and remain over there for more time. So the types of episiotomy: the median episiotomy, where it is gone vertically like this in the midline. Then the mediolateral episiotomy starts from the center and goes to one side. The J-shaped episiotomy, it starts like a median episiotomy straight down and halfway through then turns to the one side, either left or right, like in the mediolateral episiotomy. And then there is lateral episiotomy, which is usually given over here and goes laterally like this. This thing more common is the median and mediolateral episiotomies which are performed. So these two will be discussing and not discussing these two episiotomies. So midline episiotomy, in this case the two fingers are placed in the vagina between the fetal head and the perineum, and using straight scissors the incision is made from the foregut through the perineal body just short of external sphincter, anal sphincter. So the space is enlarged enough for the baby to deliver without any problem. So if you extend this incision, the external anal sphincter may be damaged. And what about the mediolateral episiotomy? Here the incision is made starting at the midline of the posterior foregut and aimed towards one of the ischial tuberosity to avoid the anal sphincter. So this anal sphincter is avoided in mediolateral episiotomy. So the angle which is usually advisable is 60 degrees from here. So once it is given, this angle of 60 degrees. When the baby delivers, this 60 degrees usually decreases to about 45 degrees. And the incision normally is given about 4 centimeters long. And the scissors which is used, known as episiotomy scissors, this is the scissors which is used for giving the mediolateral episiotomy. So in mediolateral episiotomy, in addition to the skin and subcutaneous tissues, the bulbocavernosus muscles and the transverse perineal muscles are cut. When we were discussing the muscles, then we had discussed about these two muscles. So whether the incision is to be in the right or left, it depends upon the operator preference, whether that person is right-handed or left-handed. So whichever is convenient, that direction can be used. So then there are certain merits and demerits of the mediolateral episiotomy and median episiotomy. So the merits of median episiotomy are that here the muscles are not cut, blood loss is less, repair is easy because it is a straight cut and both portions are equal, and so repair is easy over here. Post-operative discomfort is less. Healing is also better, and wound disruption is rare, and dyspareunia is also less. Well, what are the advantages of mediolateral episiotomy? It is relatively safe from rectal involvement and extension, and if necessary the incision can be extended, whereas which is not possible in the median episiotomy. So whatever the merits of each becomes the demerits of the other. And the demerits over here, in the median episiotomy, it can extend if it occurs may involve the rectum, and it is not suitable for manipulative delivery or in malpresentation because the incision may extend and the external anal sphincter may be involved. So what are the disadvantages of mediolateral episiotomy? The apposition of the tissues is not so good because it is not cut in the middle. This thing cut is sideways. So one side muscles are cut, and that's why the apposition is not proper. So even if when you give the mediolateral episiotomy, you can see one side the length is more than the other side. So blood loss is more, and the post-operative discomfort is more, and the relative increased incidence of wound disruption as compared to the median episiotomy, and dyspareunia is comparatively more in case of mediolateral episiotomy. However, the most common episiotomy which is being used is a mediolateral episiotomy. So what are the structures which are cut during episiotomy? We should know about them. This is the one is the posterior vaginal wall, superior and deep transverse perineal muscles, and bulbous spongiosum part of the levator ani. Fascia covering these muscles, transverse perineal branches of the pudendal vessels and nerve, and subcutaneous tissue and skin. We are going from inside to out in this. The steps of episiotomy: the local area is cleaned, local infiltration with the lignocaine is done. If in the mediolateral episiotomy, once this thing is given beneath the skin and beneath the vaginal mucosa, and then it is infiltrated in the fan-shaped manner. So we should, like I said, timing of the episiotomy is important. Give it when the perineum is thinned out and 3 to 4 centimeters the baby's head is visible during contraction. Use scissors to cut the perineum about 3 to 4 centimeters in the mediolateral direction and 2 to 3 centimeters up the middle of the posterior vagina. So repair of the vagina, there should be adequate exposure of the apex, and close the vagina from about 1 centimeter above the apex of the cut to the level of the vaginal opening, using the 2,0 chromic catgut or rapidly absorbable polyglectin, also known as Vicryl Rapid. 3 layers suture, first the vaginal mucosa, then the perineal muscles and the skin tissue. For vagina, continuous suturing is preferred. Perineal muscles, it can be interrupted or continuous. Usually the interrupted sutures are used, and the skin either interrupted or the subcuticular stitch is used.